Hello, I'm Joel Schuman, and it's my pleasure to be with you on CyberSight this morning or this afternoon or this evening, whatever it is for you, wherever you are. I'm going to discuss maximally effective, minimally invasive glaucoma surgery. I'm the chairman of ophthalmology at New York University, and I look forward to spending the next hour with you. First, I have a polling question. What is your level of training? 1, medical student. 2, ophthalmology resident. 3, ophthalmologist. Or 4, glaucoma surgeon. Please reply on your poll. And we have half of the group are ophthalmologists, 15% are glaucoma surgeons. We have some residents and some medical students. So we've got a good group here this morning. And let's go ahead and talk about microinvasive glaucoma surgery. So what is or are MIGS? Glaucoma surgery with a lower risk than trabeculectomy or tube implant. They often avoid disruption or even entry into the conjunctiva. There are some exceptions, canaloplasty and InFocus microstent. And the Zen is a bleb creating procedure as well. Most are designed to restore function to the conventional outflow system, with the exceptions of the gold shunt and the CyPass, in addition to the ones I mentioned above. So what's the big deal with MIGS? In general, with MIGS, you can achieve a mid to high teens intraocular pressure on average. There are always going to be those patients where you have a better result, a lower intraocular pressure, or a worse result. But on average, you're looking at a final intraocular pressure in the mid to high teens. So you have to consider whether or not the patient that you're operating on would be safe at that sort of intraocular pressure. Your choices include ab interno trabeculectomy, a trabecular bypass shunt, Schlemm's canal or Schlemm canal implants, tube shunt, or an anterior chamber to ciliary space bypass, supraciliary space bypass, or endoscopic laser cyclophotocoagulation. Let's talk about Schlemm canal surgery first. So a polling question, please answer yes or no. I have performed MIGS Schlemm canal surgery. And the answer should be coming up in just a second. And this includes all sorts of Schlemm canal surgery, whether it's removing the trabecular meshwork or bypassing it. So almost 90% of the group has not performed Schlemm canal surgery. And so we're going to talk about the different operations, and you'll see what's available to you for your patients. The mechanism of action is to increase aqueous outflow through the conventional pathway, typically through the implantation of a drainage device or removal of trabecular tissue. And here's a list of the various different either procedures or implants that can be used for Schlemm canal surgery. And we'll start off with the iStent. So the iStent is a titanium device that bypasses the trabecular meshwork and the inner wall of Schlemm's canal. And on the right, you can see a US penny, and right above the date, by the tip of the arrow, you see the implant. It's the smallest implant that's placed in the human body. And these can become obstructed and opened with a YAG laser. And they are straightforward to put in, but not necessarily easy to put in unless you have facility in operating in the angle and specifically in Schlemm canal. So these are some images of the device on the right, and on the left you see one such implant in a cadaver eye. And this is from work done by Doug Johnson at Mayo Clinic, where he looked at the effect of the iStent on intraocular, on outflow facility. This is the operation itself. There's a entry made into the cornea using a keratome, and viscoelastic is placed in the eye, and then the iStent is placed across the anterior chamber and into Schlemm canal through the trabecular meshwork and inner wall, as you see here. And the iStent is now in place. It's tapped back and forth. So in Doug Johnson's studies, one iStent doubled the outflow facility in perfused human donor eyes, and the insertion of 2 stents quadrupled it. That was very encouraging. However, the randomized controlled clinical trials did not show the degree of pressure lowering that one might expect from that sort of effect on outflow facility. And the bottom line in these studies was that the reduction in intraocular pressure was similar in patients who had phacoemulsification alone compared to those patients who had phacoemulsification plus iStent. On the other hand, the patients who had phaco plus iStent required fewer medications to control their intraocular pressure at the conclusion of the surgery. After 24 months, the pressure decrease was 8% in the phaco plus iStent group versus 1% in the phaco group. In a 5-year study of 13 combined phaco and iStent procedures, there was a 16% reduction in intraocular pressure from a baseline of 19, and 42% of those patients required no additional medication. And in a standalone iStent implant study, 27% intraocular pressure decrease was seen after a year, with a mean reduction of medicines from about 3 to 2. And then there was a retrospective analysis of standalone stent implantation on pseudophakic patients that showed good pressure lowering at 2 years from about 20 to about 13 or 14. And then in a prospective series of patients with moderate to severe glaucoma, 40% of whom had previous glaucoma surgery, at 36 months, there was a 36% average reduction of pressure from baseline and an 86% reduction in the number of medications. In a study that compared 2 with 3 iStents combined with phacoemulsification, there was a 30% pressure reduction in both groups after a year, and 46% of the patients with 2 stents were off of medications at 1 year versus 72% of those with 3 iStents. In a study that compared 1 versus 2 versus 3 iStents, 90% of patients with 1 stent, 90% with 2 stents, and 92% with 3 stents achieved a pressure reduction of at least 20%, with an absolute value of 18 millimeters mercury or less after 18 months without glaucoma medications. And with each additional stent, there was a significantly greater reduction of pressure. The iStent has been improved to a new device called the iStent inject. So placing the original iStent required entering Schlemm canal and the inner wall, passing through trabecular meshwork in the inner wall. And the newer device just requires you to inject what looks like a rivet into Schlemm canal through the trabecular meshwork and inner wall. So it's a little bit easier to place in some ways. It's a single piece device. You can see it on your right-hand side here. And it's been approved in Europe and in the US and other parts of the world. In prospective studies, the iStent inject has similar efficacy to the iStent, as we talked about just before. And in a study with POAG and pseudoexfoliation glaucoma patients, pressure decreased by 33% and 35% respectively at 6 months postoperatively following placement of 2 stents. And in both groups, there was a significant reduction in the number of medications required. In comparison with cataract extraction plus trabectome bifocal emulsification versus trabectome alone versus the phaco plus 2 iStents in the contralateral eye, the pressure lowering effects and safety profiles of the phaco plus trabectome versus phaco plus 2 iStents was similar. And this is the pivotal trial in the US for phaco plus 2 iStents versus phaco alone. And you can see that the phaco plus 2 iStent group did considerably better at 24 months than the phaco alone group. And there were similar safety profiles in the two groups. And then this study looked at the outcomes of patients for 36 months after iStent inject implantation. And again, you can see pressure lowering into the mid-teens and on average here at 36 months. Notice at the end here, the number of patients reaching this endpoint is half of those who started in the study. So you need to be a little bit careful in interpreting that. And this is the percentage of eyes with a pressure of 18 or less, so 100% at 36 months, and there were only 27% at pre-op. And at a year, it was 97% and 96%. So again, good efficacy with 2 iStent inject implanted. The next Schlem canal device is the Hydrus. So this again is a trabecular meshwork and inner wall of Schlem canal bypass device. It sits in Schlem canal. It's quite a bit larger than the iStent, and it dilates up to 3 clock hours of the trabecular meshwork. And you see the device here, and here it is in place. And you can see that the trabecular meshwork and inner wall of Schlem canal are overlying the device. And then you see the exposed tail of the device here with an inflow port. And this is the placement of the device, and this is Ike Ahmed doing the procedure. And I'm going to just speed through so that you can see the implantation. And here the inserter is being placed into the trabecular meshwork and then Schlem canal. And then the device is going to be inserted. And here you see the device going in. And then it's released from the inserter. And here's the device in place.
It helped us to visualize the canal position.
In human cadaver eyes, this device was studied by Haiyan Gang. So we have good experimental data on this. Again, looking at outflow facility. There were 14 eyes that were implanted with the Hydrus microstent. 7 contralateral eyes served as controls. And there was a significant increase in outflow facility by bypassing the trabecular meshwork and dilating Schlem canal, allowing more flow into Schlem canal and the episcleral veins. And the implantation did not cause any obvious damage to the outer wall of Schlem canal beyond the microstent entry point into the trabecular meshwork. Preliminary data on 28 patients who were implanted showed that combined phaco emulsification and Hydrus insertion resulted in a 15% reduction in pressure from baseline of 18 millimeters mercury, and medications decreased from 2.5 to 0. In another preliminary study, there was a 35% decrease in pressure from 25 millimeters mercury at 12 months. And the most common complications with all of these Schlem canal procedures are transient hyphema. And for the this Hydrus study, the formation of peripheral anterior synechiae in 10%. In the Hydrus 2 randomized controlled clinical trial, subjects received phacoemulsification plus Hydrus versus phacoemulsification alone, and were followed for 2 years. And at the end of 2 years, the mean pressure was significantly lower for the Hydrus group than the control group at 17 versus 19. And 80% of the subjects in the Hydrus group had a more than 20% reduction in their washed out diurnal intraocular pressure versus 46% in the phacoemulsification alone group. In a non-randomized prospective case series following Hydrus implantation, the difference in pressure between the groups was not significant, but the Hydrus group had significantly greater medication reduction than the SLT group. And in less than 10% of patients, there's a transient early pressure spike from baseline. And here are some data from that study. This is the Horizon study. And this was a randomized control clinical trial of phaco alone versus phaco plus Hydrus in 369 eyes and 187 control eyes. And here you can see the percent of eyes with more than 20% reduction in intraocular pressure compared to baseline, and the numbers for Hydrus are significantly higher than the numbers for phaco alone. And here you can see the results graphically in terms of the percent that were unmedicated at each time point. Let's turn now to Trabectome. Now, we're going from putting devices into Schlemm canal to removing the trabecular meshwork and the inner wall of Schlemm canal. And so Trabectome is one device for doing that sort of an ab interno trabeculectomy. It ablates the trabecular meshwork and the inner wall of Schlemm canal, and that allows greater outflow facility. It uses a high-frequency electrocautery, which is used to ablate the tissue. The most common complication, as with all these Schlemm canal procedures, is hyphema. And here you can see the device. This is the portion that sits in Schlemm canal. This is a schematic showing trabecular meshwork and Schlemm canal here. And then this is the outer wall of Schlemm canal. And this is illustrating that the heat on this side of the probe is not very great. It's only increasing the temperature by 1.2 degrees Celsius, whereas on this side it is extremely hot. It's a plasma. And you can see the intact trabecular meshwork and outer wall and inner wall of Schlemm canal here, and then the ablated tissue here. And this is the outer wall of Schlemm canal that you're looking at after removal of trabecular meshwork and the inner wall. Here you see the remnants of trabecular meshwork and inner wall on this scanning electron micrograph. And this is the procedure being performed. This is being done by Niels Lowen, who has done as many or more of these procedures as anybody globally. And in his technique, you can see that the device is sliding easily across the trabecular meshwork and inner wall, ablating that tissue. And he's very careful not to rub the outer surface of the probe against the outer wall of Schlemm canal so as not to damage the outer wall or collector channels. The other little trick that Dr. Lowen introduced, widening the cornea with the keratome here, and then widen the entry to each side, which improves your access to the trabecular meshwork and Schlemm canal with the probe, so you can ablate a wider area of the angle. The other little trick is when entering with the trabectome to enter and moving anteriorly into trabecular meshwork and Schlemm canal initially, and then advance parallel to Schlemm canal. And again, never rub against the outer wall. This is that scanning electron laser photomicrograph, and you can see the smoothness of the outer wall and the intact cell layers, the cell layer of the outer wall and collector channel here and here. So these collector channel ostia are not damaged when performing trabectome in this way. You don't want to push outward against the outer wall while you're doing the ablation. There really are not prospective randomized clinical trials to show you for this type of surgery, but there are case series. And in patients who were followed for a year postoperatively, postoperative medicated pressure of 16 from a baseline of 28, and a decrease in medication usage from 1.2 to 0.3. And subjects with pseudoexfoliation glaucoma had a robust response to trabectome, even better than those with primary open-angle glaucoma. This is from the paper by Don Minkler, George Beervelt, Marina Alfaro, and Brian Francis, showing the reduction in intraocular pressure with this device. And again, you're achieving mid to high teens final intraocular pressure on average with trabectome. And again, here are some more studies looking at the same thing in terms of final intraocular pressure, mid to high teens, and then a reduction in the number of medications required. And this Kaplan-Meier graph shows failure pressure greater than 21 and not reduced by 20% below baseline for 2 consecutive visits. Let's turn now to the Kahook dual blade, which was introduced after trabectome. And the Kahook dual blade allows the removal of trabecular meshwork and Schlemm canal, but without cautery. So this is a device that is inserted into Schlemm canal and then lifts the trabecular meshwork and inner wall so that it's on stretch, and then 2 blades on either side of that incline slice through the anterior and posterior portions of the trabecular meshwork, allowing you to remove that tissue without tearing. And this obviously is a much less expensive device. It has the blade here at the tip, and it's simply this hand instrument. There's no machine involved. Again, no randomized controlled clinical trials to date. Preclinical studies were done by Dr. Kahook, who actually had invented this device for use in the laboratory so that he could study trabecular meshwork, and then realized that it might be a useful clinical tool. And in the clinic, it shows good efficacy, mean pressure reduction of 28% at 1 year in combination with phacoemulsification, and 64% of subjects having a reduction of at least 1 medication. And here you see the intraocular pressure results comparing the phaco and Kahook dual blade ab interno trabeculectomy or goniotomy and the phaco iStent procedures, and you see a similar outcome for the 2. And then here you see the proportion of patients with a pressure reduction of 20% or greater, and the Kahook dual blade achieved a larger proportion of patients reaching that target than the phaco iStent patients. And again, looking at phaco iStent versus phaco Kahook dual blade ab interno trabeculectomy, you have a greater reduction in intraocular in the number of medications required. And here again, this is another representation of reduction in medications by at least 1 from baseline. All right, we're going to turn now to TRAB 360. So this is using a device, a handheld device made by Sight Sciences, and it is another way for performing an ab interno trabeculectomy. And it's designed so that you can access all 360 degrees of Schlemm canal in 1 clear corneal incision. So unlike the prior procedures, which give you access to between 2 and 6 clock hours, depending on how adept you are, with this device, you open the entire 360 degrees of Schlem canal to increase outflow facility. Again, no randomized clinical trials to date. Preliminary studies for the TRAB 360 show good pressure reduction from 20 to about 13.5, and reduction in ocular hypertensive medications from about 1 to 0.2. And less than 1 year postoperatively, 73% of patients were controlled on no medications. And now let's look at gonioscopy-assisted transluminal trabeculectomy, otherwise known as GATT. GATT is, again, a way of doing a 360-degree opening of Schlem canal to the anterior chamber. You are placing a device into Schlem canal and then opening the entire circumference of Schlem canal. This is done with either a microcatheter or a 4-0 nylon suture with the tip blunted. So this can be a very inexpensive procedure if you're using a suture, less inexpensive if you're using a microcatheter. Through that single goniotomy incision, you advance the catheter or suture 360 degrees and then pull the ends to open the trabecular meshwork and inner wall. Sometimes you do need to re-enter Schlem canal if you can't go all the way around on the first pass, but most often you can get 360 degrees with this procedure. A preliminary study of 85 patients who had GATT by 4 surgeons. This is the group that actually developed this procedure for adults, found an overall decrease in pressure of 40% at 12 months, so a reduction of 11 millimeters mercury. No difference in pressure reduction with or without concurrent or prior cataract extraction. So this surgery is not in combination with phacoemulsification, nor were the prior two. The GATT was not studied in this case compared to phacoemulsification alone. And TRAB 360 and Kahook dual blade also have been studied in the absence of phacoemulsification. In a small retrospective review of subjects with juvenile open-angle glaucoma and primary congenital glaucoma, where 360-degree goniotomy has been shown to be effective, the pressure decreased from 27 to 15 over 12 months with a reduction in glaucoma medications from 2.5 to 1. Okay, now we're going to talk about canaloplasty or ab interno canaloplasty. Canaloplasty was introduced first, a surgical technique that consists of taking down the conjunctiva, dissecting a scleral flap, removing a block of sclera to form a lake, and then entering Schlem canal with a catheter and dilating the canal with viscoelastic, and then placing a tensioning suture in the lumen of the canal with the aim of ultimately improving outflow facility and lowering intraocular pressure. And this is the device that was used for that. There's a rounded tip on the catheter. The catheter is 200 microns in diameter. And then the catheter contains a support wire to give it some stiffness. It has an optical fiber for light transmission, and then polyamide tube to infuse fluid and aspirate. And so this device would be placed in Schlem canal dilated, a suture placed on the end of the device, and then the catheter pulled back through Schlem canal, and the suture tied off to cause tension in Schlem canal, and that puts some stretch on trabecular meshwork and the inner wall of Schlem canal as well as the outer wall. And this is the suture in place in cross section. So that is really not a minimally invasive glaucoma surgery. The aspect of canaloplasty that can be minimally invasive or microinvasive is ab interno canaloplasty. So in contrast to traditional canaloplasty that I just described, this does not require conjunctival or scleral dissection. And here, under gonioscopy, the microcatheter is inserted into Schlem canal through an ab interno approach. There are no clinical trials published on this to date. And you can decide whether you're going to actually do canaloplasty, just dilating the canal, or actually do a GATT, where you take the two ends of the catheter and pull them across each other, opening the Schlem canal 360 degrees. So this is sort of like the procedure I described just before, GATT, except that in ab interno canaloplasty, you're simply doing viscodilation of Schlem canal. In GATT, you're actually tearing through trabecular meshwork in the inner wall to open Schlem canal to the anterior chamber. Finally, excimer laser trabeculotomy. And this procedure is not commonly performed. It requires a very expensive instrument, and the instrument also is mutagenic. This is an excimer laser that can be delivered through an aqueous environment. It's 308 nanometers xenon chloride. And this excimer laser can be used to create microperforations in the trabecular meshwork. You can see how the procedure is done schematically here. The procedure is done gonioscopically. It is not approved for use in the United States. It has been done in Germany and other places. But because of the mutagenicity of this wavelength of laser, I am somewhat concerned about this procedure, especially since the intraocular pressure results are modest. This is even compared to SLT, selective laser trabeculoplasty. And you can see that by 2 years, the two procedures are very close in terms of intraocular pressure effects. I'll talk about a couple of devices for bypassing the conventional outflow system and implantation in the suprachoroidal space. But first, how many have performed suprachoroidal shunt surgery? Answer 1 for yes and 2 for no. And we see that most people have not performed suprachoroidal shunt surgery, 80%, and 20% have. So we really have two devices now for suprachoroidal space surgery. One is the CyPass, and the other is the iStent Supra. Let's talk about the CyPass first. So this device was introduced, and it's a fenestrated, flexible microstent that is threaded through a guide wire that follows the curvature of the sclera, It is threaded through a guide wire that follows the curvature of the sclera, enabling supraciliary bypass. It's inserted through a single corneal incision, and the device is placed gonioscopically. And there is a cuff here at the top that maintains the stent's position in the anterior chamber, and it's composed of polyamide material. There have been several studies of the CyPass, and they were quite encouraging, reporting a very good reduction in intraocular pressure and decrease in the number of medications required. And the COMPASS study was the largest and longest of those studies, and again had a a good intraocular pressure reduction and a great reduction in medications with adverse events similar to phacoemulsification alone. However, it turned out on the 5-year follow-up that there was significant reduction or loss of corneal endothelium. And because of that, the device was voluntarily withdrawn from the global market by Alcon, and the FDA issued a communication, the US Food and Drug Administration issued a communication regarding the risk of damage to corneal endothelial cells following CyPass implantation. So this procedure at this point in time is no longer being performed. In that study, 27% of patients had a more than 30% loss in corneal endothelial cell density. And it was correlated with the number of rings that could be seen. So the more anteriorly the device was placed or left, the more likely it would be that there would be corneal endothelial cell loss. And for those of you who have implanted the CyPass, the recommendation is careful monitoring postoperatively and either trimming or removal if the corneal endothelial cell loss is occurring, or if significant corneal endothelial cell loss is occurring. The trimming of the device is not easy because it is a stiff polyamide device, and the removal of the device is extremely difficult without causing damage to the tissue. So this presents a problem for those patients who have had CyPass devices implanted. Let's talk about the iStent Supra. This is not available in the US at this time, but it does have a very similar appearance to the CyPass, and the future of this device is still uncertain. It has similar success to what was reported for CyPass. The corneal endothelial cell results have not been released. We can also reduce aqueous production with endocyclophotocoagulation. This really is not a new procedure. This procedure has been around for a while. So have you performed endocyclophotocoagulation or not? Yes or no? And the answer should be up in a couple of seconds. Again, this is a procedure that's been around for about 20 years. And 80% have not done this procedure, 20% have. So endocyclophotocoagulation is a procedure where you're using a laser to treat the ciliary processes and cause coagulation necrosis, fusion, and fibrosis of the ciliary processes, decreasing the amount of aqueous being produced by the eye and thereby lowering the intraocular pressure. You really need to treat between 3/4 and 360 degrees, 270 to 360 degrees of the ciliary processes, and you want to treat them as completely as you can. You will invariably leave significant epithelial tissue behind. When the processes are treated, you see this whitening and shrinkage of the ciliary process. Here's a normal process right adjacent, another normal process. And so when you're treating them, they shrink and turn white, and you're still leaving quite a bit of epithelial tissue in between and posterior to the area that's being treated. So the likelihood of developing hypotony or ptysis with endoscopic cyclophotocoagulation is extremely low. There are no randomized trials comparing ECP to conventional transscleral cyclophotocoagulation, but it does seem to be a kinder, gentler type of cyclophotocoagulation with lower complication rates. There is inflammation associated with endocyclophotocoagulation, but it may be similar to or maybe a little bit less than trabeculectomy in the long term, and compared to a tube shunt procedure, ECP has similar outcomes in some cases. I would say that that endocyclophotocoagulation is a reasonable choice in many patients, but there can be complications, certainly more severe than with other minimally invasive glaucoma surgeries, and those complications could include cystoid macular edema and retinal detachment and corneal injury, as well as iris injury. And this is from a prospective non-randomized case-matched controlled case-matched study comparing ECP plus phacoemulsification versus cataract surgery with phacoemulsification alone in patients with medically controlled glaucoma. And this was the study group, and this was the phaco alone group. So you can see that the success is certainly higher in this group with the addition of the endocyclophotocoagulation. And then this is from a retrospective chart review comparing ECP plus phaco versus phaco alone. The blue is ECP plus phaco, the light blue, phaco alone. And same here with regard to the number of medications. All right, the last thing that I want to talk about is bleb-forming surgery. And in that area, I'd like to know how many who are listening have performed bleb-forming surgery other than trabeculectomy. If you have, answer yes. If not, please answer no. And the answer should be up momentarily, and we'll see how many have done bleb-forming surgery other than trabeculectomy, and it's 50-50. Okay, so a lot more familiarity with the gold standard procedures, but some familiarity with the non-trabeculectomy bleb-forming surgeries. So the two that I'll talk about are the Zen 45 gel stent and the InFocus microshunt. So first the Zen. This is the Zen here on this person's fingertip. And it's a hydrophilic collagen tube with a 45 micron lumen. It becomes flexible when it's hydrated. So you really want to put it in unhydrated. And the diameter of the lumen was selected to minimize hypotony. This device and the InFocus use Poiseuille's law in order to reduce the risk of hypotony with bleb-forming surgery. This is preloaded into an injector. It's supposed to be used for ab interno injection, where a keratome is used to enter the anterior chamber. The chamber is filled with viscoelastic, and then the device is placed on this needle across the anterior chamber and then through the angle, through the sclera, and emerges subconjunctivally, and then is injected through the needle so that portion 3 millimeters remains subconjunctival, 2 millimeters in the sclera, and 1 millimeter in the anterior chamber, ideally. There are some people who are using this device ab externo, but that is certainly off-label use. Time will tell which of the two uses is actually better. The device allows you to use an antimetabolite like mitomycin C in order to increase the likelihood that the bleb that you create will survive. The early prospective studies use large lumen tubes that are not recommended because of hypotony and flat chambers. The initial study of the Zen 45 showed good efficacy, so pressures in the low teens, and a good reduction in the number of medications. Small prospective non-randomized case series with mitomycin C and phacoemulsification, you can see a good reduction in intraocular pressure and a reduction in the number of medications. The one issue with the Zen is the issue of encapsulation over the tip of the tube subconjunctivally. In about 30% of cases, needling with mitomycin C, so a needle bleb revision with mitomycin C, is required in order to restore function to the Zen gel stent surgery. And the needling procedure is relatively straightforward, but the high rate of needling is somewhat unique to this particular device and procedure. And the last procedure that I want to discuss is the InFocus microshunt. This is a new device that's made of a material that's used in coronary artery stents, has been used in the body for a long time, called SIBS. And the data on these implants are amazingly good. We'll see once the device has been implanted in a large number of people what the results are, but the results that have been published so far, you can see starting pressures in the mid-20s and final pressures in the low teens. So that is very encouraging. The InFocus does require that the conjunctiva be opened in order for the stent to be placed. It's an ab externo procedure only. So this is not a procedure that can be performed ab interno. And the material that's used is what is unique for this device. Again, the early results are very, very encouraging. So what is the impact of all the different surgeries that we've been talking about? Well, you have to ask who is a candidate for microinvasive glaucoma surgery. And really for people who are going to have Schlemm canal surgery, you're really talking about early to moderate glaucoma. This is, in general, not a surgery that you would perform on people with moderate to advanced glaucoma, because the target pressure for the later group is going to be in the mid to low teens, whereas for the earlier group, you're going to have a target in the mid to high teens. And so if you're okay, if the patient you think will be safe with a mid to high teens pressure, then Schlemm canal surgery may be appropriate for that patient. And you have this whole list of procedures that can be performed and are likely to achieve that sort of target pressure on average. For patients who are having Schlemm canal surgery, this is a controlled way of lowering intraocular pressure. So the biggest advantage is that there's less risk than with trabeculectomy or with a glaucoma drainage device implant. You don't have the same degree of risk of scarring and endophthalmitis that you do with those surgeries when you're doing Schlemm canal surgery. But the trade-off is that there's less pressure reduction than those more invasive glaucoma procedures. The safety of the ab interno Schlemm canal surgery allows implementation of these procedures earlier in the treatment regimen. So in many countries, I'm sure for many of those who are listening, glaucoma is primarily a surgical disease. And so in patients who have early to moderate glaucoma, these offer an excellent option. If medications are available, you may choose to use medications before introducing these operations. But if medications are not available, or follow-up is going to be poor, or adherence to therapy is going to be poor, these surgeries are not a bad choice. That does not mean that selective laser trabeculoplasty or argon laser trabeculoplasty would not be appropriate prior to introducing these surgeries. It depends on the patient, and every glaucoma patient is unique. So these are just general rules that I'm stating. But efficacy issues really restrict these surgeries to people with mild to moderate disease. For people who have moderate to advanced glaucoma, you really want a target pressure in the low to mid-teens. And there, we're talking about a bleb-forming procedure like the Zengel stent or the InFocus microshunt if you're going to do the microinvasive surgical techniques, or the more gold standard trabeculectomy or glaucoma drainage device. The advantage of the Zen and the InFocus is that they are less risky than the trabeculectomy or glaucoma drainage device. On the other hand, it is not clear that the efficacy with these devices is at the same level as trabeculectomy or glaucoma drainage device. So which MIGS is best for which patient? Well, if you have a patient like this one, where you have early to moderate glaucoma damage, here a mean nerve fiber layer thickness of 72, the patient is getting worse, although not very quickly, and not a tremendous amount of damage. Again, this is a patient for whom microinvasive glaucoma surgery or minimally invasive glaucoma surgery might be appropriate. On the other hand, a patient like this would do better with a bleb-forming surgery. Bad glaucoma, getting worse fast. In these patients, a bleb-forming operation would be the best choice for the patient. Thank you very much. So the first question is whether it's absolutely necessary to use antimitotics for an effective glaucoma surgery. And the answer is usually yes. If you're going to do a bleb-forming surgery, your best bet is going to be to use an antimitotic. In general, for any glaucoma surgery, with the exception of a glaucoma drainage device like a Maltino or an Ahmet or a Barvelt, the antimitotic is going to be necessary for success. And so I would say yes for the bleb-forming procedures. The second question is, how can patients with advanced glaucoma benefit from MIGS? And as I mentioned, MIGS using the Zengel stent or the InFocus microshunt are useful even in people who have advanced glaucoma. And so I do use these procedures, and many people do, in that setting. So it all depends on what your target pressure is. If your target pressure is in the low teens or low to mid-teens, then you need to go with a bleb-forming procedure to be likely to achieve that pressure. If your target is in the mid to high teens, then Schlem canal surgery would be appropriate. The third question is, how deep do you go in sclerectomy? And so in a deep sclerectomy, you go 90% thickness. In a trabeculectomy, you go about 50% thickness. So if you're doing a trabeculectomy, you want to make your trabeculectomy flap about 50% thickness, and maybe you'll make it about 3 by 3 millimeters. Some people like to make it a little smaller, some people like to make it a little bigger, some people like to make it triangular, some trapezoidal, some square. It doesn't matter. It matters that you have adequate thickness to restrict flow, and it matters that the TRAB flap is big enough to cover the sclerotomy. In a deep sclerectomy, you make the initial TRAB flap, and then you make the additional 40% flap after that. Next question, how does one go about patient selection for MIGS? And so patient selection for MIGS is based on the severity of the patient's disease and whether or not the angle is open. If the angle is closed, doing angle surgery is much more difficult, and it's not obvious that you are going to get the same results with angle surgery as you do in patients who have open angle glaucoma. Also in neovascular glaucoma, it's not clear that you would get the same sorts of results as you do in other open angle glaucomas and in ICE that same story. It's not clear that you would get the same benefit. And so in those patients, you might want to go with a trabeculectomy or tube implant, or one of the bleb-forming MIGS. But for the most part, for Schlem canal surgery or for suprachoroidal space surgery, you want to have a patient who has early or early to moderate disease. The next question is, how effective is MIGS compared to traditional TRABs? And so with a traditional trabeculectomy, you can expect to get a final intraocular pressure in the low teens, maybe even the single digits. And those numbers are necessary for patients who have advanced disease. So MIGS are not going to get you there unless it's a bleb-forming MIGS procedure. And if it's Schlem canal surgery, it's very unlikely that you will achieve that sort of pressure. The next question is, how will MIGS reach the developing world? And I think that the answer to that has to do with a number of factors, and cost is not an unsubstantial factor. So things like the Kahook dual blade really make it possible for people in the developing world to perform MIGS, since the device is a type of a knife or a blade, and does not require machinery. So it's a much less costly way to remove the trabecular meshwork and the inner wall of Schlem canal than the other ways of doing that procedure. And it is not a device that you leave in the eye. So you don't need hardware left behind in order to perform that procedure. So I think that that is one type of MIGS that has the most facile entry into the developing world. Now, many of the patients in the developing world have very bad disease. They may not be seen until their glaucoma is quite advanced. And so for those patients, the Kahook dual blade is not a good choice. And if the implants like the Zen and the microshunt, the InFocus microshunt, are not available to you, then trabeculectomy is really going to be the best option, or a glaucoma drainage device, if that's available. But I would say that economics has a lot to do with the ability of MIGS to reach the developing world. The first question is, what's the best option for neovascular glaucoma? And I believe that neovascular glaucoma is usually best treated with a glaucoma drainage device, although there are certainly plenty of cases that do well with a trabeculectomy. Also, if the glaucoma damage is very bad in the patient with neovascular glaucoma, trabeculectomy is the only thing that's going to get the pressure lower enough to protect the optic nerve. On the other hand, that type of glaucoma is notorious for causing scarring and failure of the trabeculectomy bleb. So you want to make sure that you've treated the neovascularization and the inflammation associated with it prior to performing the trabeculectomy, if at all possible. The next question is the cost of stents. And so that is going to depend on your location. The stents in the US cost anywhere up to $2,500 or more for some of these implants. And so it is not an inexpensive venture to perform MIGS with these devices, but the actual cost is going to depend on your location. The next question is it a must to combine MIGS with cataract surgery? And the answer here has to do with economics again. So in the United States, most of the MIGS implants are approved for use with cataract surgery because that's how the clinical studies were performed, and that is how they're approved by the FDA. And so the payers in general will only pay for the device if it is implanted in conjunction with cataract surgery. Some of these devices do not require cataract surgery in order for the insurer to pay for the operation, but many of them do. And so that is a complexity that has to do with the US payment system for medical care. The next question is, when do you choose MIGS over SLT in your patients with mild to moderate glaucoma? And personally, I perform SLT if I think that I am likely to achieve the target pressure with that procedure. So if I think that the SLT is likely to be successful and adequate, I will perform that. If it fails, then I might move on to MIGS. But if I have a chance to control the pressure with a less invasive, less risky procedure, I would prefer to do that. Next question is, what should one prefer for early glaucoma, MIGS or laser? I think that's the question that I just answered, although this one looks at SLT and micropulse. So here we're talking about a stimulatory procedure. SLT stimulates the trabecular meshwork to improve its function and lower intraocular pressure in that way, whereas micropulse is a cyclodestructive procedure. It also may cause some more porosity or increased outflow through the unconventional outflow route, and the inflammation caused by micropulse may also have some effect on the trabecular outflow. But I would prefer to perform SLT in a patient, and I usually reserve micropulse to later in the treatment course if that patient has failed incisional surgery, or if the patient is too sick to undergo incisional surgery, then I would consider micropulse or conventional transscleral cyclophotocoagulation. The next question is, what about its effectiveness on Black patients? So for the Schlem canal surgeries, the effectiveness appears to be similar in Black patients and in non-Black patients. For the blood-forming surgeries, for Black patients of African origin, it is much more risky for the Black patient than the white patient in terms of the likelihood of failure due to scarring. So much more reactive conjunctival and episcleral tissue, and therefore those patients have to be watched more closely and may need needle bleb revisions, or may need another or a second operation in order to be successful. And so that is certainly a consideration anytime that you're operating on Black patients, especially Blacks of African origin. The next question is, in GATT or angle surgery, how do you manage if bleeding occurs at the time of cutting trabecular meshwork? And so it's typical that bleeding will occur at the time that you enter the Schlem canal, or when you depressurize the eye, if it hasn't occurred at the time that you've entered. If you have a relatively high pressure during the entry period, it does make it a little bit more difficult because Schlem canal collapses a bit. So the lower pressure allows you to visualize Schlem canal from blood reflex, and also that gives you a target. But it also does result in a little bit more bleeding at the time of device placement or removal of the trabecular meshwork tissue. If you do have bleeding, you can pressurize the eye, and you can use viscoelastic to try to clear the area. And if that's not effective, you may need to either move to a different area or a different procedure. The next question is, can repeated MIGS procedures be performed? And the answer is, it depends on which procedure. So if you've put in an iStent or iStents, then yes, you can perform removal of the trabecular meshwork and inner wall to open Schlem canal. You can perform GATT or TRAB 360 or canaloplasty. If you've removed the trabecular meshwork and inner wall, your options are really limited. There you can remove the remaining trabecular meshwork and inner wall that you have not removed with the initial Trabectome or Kahook blade procedure, or you can do a blood forming procedure, or you can do a suprachoroidal shunt. The next question is how many procedures can be done with a single Kahook blade? And the answer, at least in the US, is one. The fact is that the blade may still be sharp enough to do additional procedures, but it's a single-use device in the United States, and it's labeled that way. And so we can only use it once. But we know that there's a lot of waste in the medical system, and many devices that are labeled for single use actually are good for repeated use. So that's a long-winded way of saying I don't know, but I'm sure that the procedure can be done effectively more than one time with a single blade. The next question is, can MIGS be done for congenital glaucoma? And the answer there is yes, but what you want to do in those patients really is open Schlem's canal. And so the use of GATT or TRAB 360 is a good option in people with congenital glaucoma, as opposed to a simple goniotomy, which could also be done. The success rates are higher for the GATT or TRAB 360, but goniotomy with a blade is useful because the tissues fall back in congenital glaucoma, unlike in adults. Or you can use the Kahook dual blade or the Trabectome in that setting, and that works as well. But you're not opening as much as of the angle as you do with the GATT or the TRAB 360. Thank you very much. I think that's everything.